I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and peri-menopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. You're tuned into the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely, and my guest today is Dr. Laura James, naturopathic oncologist. And if you've ever had a friend, a family member, a loved one, or yourself gone through the process of a breast cancer diagnosis and wondered, was there something different for you? What were your choices? What does all this diagnostic information mean in terms of therapy? Are there things you can do to support the traditional way of treating cancer? And Dr. James is here to deliver that information for us today. Now, we had a wonderful conversation, but I just want to warn you that you might want to have some earplugs in if you've got some sensitive ears around, because there's some spice to this conversation. I found out recently that a friend of mine, whenever I send her voice memos, she says, "Oh, I never listen to those just on play where anybody can hear them." So I figure if you're a friend of the show, you've listened to the show for a while, chances are you probably already know about the AirPods, earmuffs, earplugs, whatever you want to call them. You know what I mean. Sensitive ears around. So the questions I asked Dr. James was things that I think you guys might want to know. What is a naturopathic oncologist? How does a naturopathic oncologist work with a traditional oncologist? And what do women experience when they're going through a breast cancer diagnosis? What does she talk to her patients about? And, why you would want to seek treatment with a naturopathic oncologist along with your Western medicine oncology treatment. And I also ask her, what's her greatest hope for women and breast cancer going forward? She had some interesting things to say. We talked a lot about biases in medicine, etc. Again, a real juicy conversation. I love meeting women like Dr. James because I wouldn't get to meet her otherwise, even though her practice is in Seattle, and that's not all that far here from Western Canada, but we just likely wouldn't be in the same room together. So I'm just so grateful to have a new friend, to have a great conversation, and to share that information with you, my beautiful listeners, because I know somebody in your world could use the information that Dr. Laura James shared with me today. Let me introduce my guest. Dr. Laura James is a naturopathic oncologist in private practice in Bellingham, Washington, with extensive training in safely managing complementary and alternative therapies for cancer patients undergoing conventional cancer treatments. She provides complementary medicine consultations regarding the whole foods nutrition, botanical medicine, nutritional supplements, and lifestyle modifications to attain optimum health during cancer treatment and beyond. In 2002, Dr. James founded Red Cedar Wellness Center, an interdisciplinary integrative health clinic for adults in Bellevue, Washington, where she served as medical director until 2018. In 2022, she founded Best for Breast LLC, a supplement line for women with a history of breast cancer or those at high risk, and Integrative Breast Solutions LLC to educate women worldwide about developing an integrative roadmap for their cancer care. Dr. James holds a bachelor degree from Tufts University in Boston and a doctorate in naturopathic medicine from Bastyr University in Seattle. She's a fellow of the American Board of Naturopathic Oncology and has served on the board of Team Survivor Northwest, as well as adjunct faculty at Bastyr University's Center for Natural Health. She collaborates with major medical institutions around the Puget Sound area on implementing integrative medicine programs for cancer patients. You can find her on her website at laurajamesnd.com, also bestforbreast.com. Without another moment's wait for you, I know you're going to enjoy this one. Here's my conversation with Dr. Laura James. Welcome to the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely, and today my guest is Dr. Laura James, naturopathic oncologist. Dr. Laura, welcome to the show.
Thank you for having me, Fiona. I'm really happy to be here.
Oh, it's my pleasure. It really is. And this is a conversation we have not had on this show, despite this podcast being 10 years old this coming year. Isn't that cool?
That's amazing.
I know. I like to say this on the show, but when I started the podcast, there were no other menopause podcasters. I was literally the first, and I'm still here and still doing it.
Well, and nobody was really talking about menopause openly.
Nope. No,
so,
we barely are now.
We are. Now it's very open.
It is really
Gen X for that. Yeah.
That's what I say to the younger sisters. Like yesterday, I had two millennial aged women in the office and seeing me for various things. And I got to break it to them that actually they were not losing their minds, having a brain tumor, et cetera, that they were just simply perimenopausal. And so that is, I'm so grateful for that conversation. And it's really because of us Gen X shit stirrers. We were not willing to go through this quietly like our mothers did.
Correct.
Thank
Absolutely.
God.
There's no reason to go through it quietly. And I mean, over the last 30 years, I've seen all sorts of different interventions and better interventions. And now much better conversations about what the options are, right?
Absolutely. Absolutely. You bet. And I'm totally here for it myself. And, we could go off and talk about that, but really I want to dig into what you do. But please tell me, how did you find yourself a naturopath?
Well, I started out as a writer. That was really my first love and what I did in college. And I found myself in my very first job after graduating from college working in a medical setting. I worked for a large cancer research hospital on the East Coast in the US. And I was writing grant proposals. I was in the development office. So I was doing all fundraising kind of work, but there was a ton of writing involved. And I had the opportunity to go talk to the scientists in the laboratories, because this was a big research hospital, and try and understand what they were doing so that I could write a grant proposal in much less technical terms for the foundation or the people or whomever, was going to be receiving this grant proposal. And I found that I really, really enjoyed that, but I also really nerded out on the science. And I did have a minor in biology when I was in college. So I was already sort of interested in natural sciences. And I worked as a medical writer for about 8 years, and it took me a little bit to sort of work up the courage to apply to medical school. And it took me a year and a half, really, to decide whether or not I wanted to go to conventional medical school or naturopathic medical school. And the decision was really all about nutrition. And at the time, in the mid to late 1990s, nutrition was barely on the radar of conventional medical schools. And it was very fully on the radar of naturopathic medical schools. And so that was really the tipping point for me, because for my own health, I found that making dietary changes had a huge impact. And, this was in the late 1980s, early 1990s. Nobody was making nutritional recommendations in Boston, right? But somehow I found this great, team of providers that were like, well, why don't you try this? And why don't you try this? And why don't you try this? And I was like, holy moly, this is the intervention that I've been looking for a long time.
The AG1 you've all heard me talking about for so long just went through a major upgrade. AG1's next gen is here. It's the same single scoop once a day, but now it's clinically backed and formulated with more upgraded vitamins, minerals, and probiotics. The new next gen formula offers a more advanced, clinically backed formula that fills common nutrient gaps and supports gut health, all in the same easy, once a day ritual. AG1 has been a game changer for my mornings. It sets the tone for my day, helps me feel my best, and like I'm taking care of my nutrient needs in one step. AG1's Next Gen includes 5 clinically studied probiotics and additional vitamins and minerals to support whole body health. Now clinically backed with an advanced formula, this is the perfect time to try AG1 if you haven't yet. I've been drinking AG1 daily for 6 years now, and I'm so happy to be partnering with them. Subscribe today and try the next gen of AG1. If you use my link, you'll also get a free bottle of AG D3K2, that's vitamin D3K2, an AG1 welcome kit, and 5 of the upgraded AG1 travel packs with your first order. So make sure to check out drinkag1.com. That's drinkag1.com/Fiona Lovely to get started with AG1's Next Gen and notice the benefits for yourself. That's drinkag1.com/Fiona Lovely.
And, it was really interesting because I have a lot of friends who are conventional medical providers. And at the time also had, friends and acquaintances that were part of my family, friends and acquaintances who kept saying to me, don't do the naturopathic route, go the conventional route, because if you think differently, maybe you can make changes from the inside as opposed to trying to, break in on the outside. And so that was really how I got to naturopathic medical school, was because I was so interested in the power of nutrition. And that's what I ended up spending a lot of time, all my electives. I spent a lot of time in the nutrition department when I was a student at Bastyr in Seattle. And it's something that I talk to my patients about in every visit. It's a very important piece of their health and well-being.
Absolutely. And isn't food the original medicine?
Mm-hmm. I'd much rather have people spend money on good quality food than on a whole bunch of supplements that have dubious, efficacy
Yep.
anyway.
Yep, exactly. There's so many questions about how you come to these formulations, but beside the point, let's come back to food. I'm not sure that med schools even now really even talk about nutrition.
I think there may be a little better. I think it depends on where you go, but the generation of young people who are going into medical school now either have parents my age
Yep.
who are maybe more attuned to dietary interventions for health, or it's just the social media environment that we live in. And there's some good influencers maybe out there who are encouraging people to eat well. So, it's unfortunately everything that we do requires a level of science that may or may not really be giving us a good answer, right? And just like the menopause conversation of, all right, now we're getting some science, or now people are looking at the science that was done before and recognizing it for what it was, right? And I think nutrition is pretty much in the same kind of place. Although science regarding nutrition is really, really difficult because it's hard to control, right?
Yep.
It's hard to control for different dietary interventions. You'd have to put somebody in a black box and feed them through a little hole to make it perfect randomized controlled trial,
Not
right?
sure
Regarding
perfect is the right
nutrition.
word. Yeah, but you're right. You're totally right. And
Mhm.
also, nobody wants to pay for that, right?
Nobody wants to pay for it. No,
No,
it's
no.
food. Yeah,
Yeah,
it's food.
yeah. If human beings are quite content to eat junk food, then why would we pay for
Mhm.
studies on great food? So,
Mhm.
so tell me, what is a naturopathic oncologist?
So first and foremost, I'm a naturopathic physician, which means in the state where I live, which is Washington State, I'm licensed as a primary care physician. So I have a big scope of practice. I can diagnose, I can treat, I can write prescriptions, I can be covered by insurance. Canada, I know province by province has their rules and regulations for
Yep.
naturopathic doctors, but Canada also licenses um, naturopaths.
Mhm.
And probably, I want to say 15, maybe 20 years ago, a small group of providers, including a few Canadians, who were already working with patients with cancer in a very intense way, sort of pulled together to start developing standards and an education process, a board certification process. So, those of us who are board certified in naturopathic oncology not only have natural medicine under our belts, but we have a lot of conventional oncology wisdom as well. And really, what we're all doing is integrative oncology. We're working with patients who are doing traditional standard of care cancer treatment, and we're helping them do it. We're helping them prevent side effects
Mhm.
so that they can finish their treatment. We're helping them recover from surgery. We're helping them heal from chemotherapy and radiation. And we're providing a really holistic viewpoint because let's face it, conventional medicine is hopelessly siloed, right?
Mhm. Mhm.
And oncology is the same thing. And in many cases, I end up being sort of like a primary care physician for patients who have had breast cancer because at a certain point their oncology team just kind of drops them. They're like, okay, we're done, the time is over. And these patients are like, what the hell, I
Now
what do I
what?
do now,
Yeah,
right?
yeah, yeah.
And so I end up working with these patients long term with that lens of, oh, this patient had breast cancer. She's done this chemotherapy. She's done this radiation. She's had these surgeries, right? These are going to influence our decision making process, right?
Yeah.
So, at any rate, there are only like 150 of us in North America.
Mhm. Mhm.
We are a very small field of providers, and we get together once a year and we dig into the research and we support each other as well as we can.
Amazing.
And we all have relationships with conventional providers and conventional cancer centers wherever we live because we fought really hard to have good relationships with what's available for patients in our communities.
Yeah, yeah, and thank you for that because I know that I refer in my own patients that have new cancer diagnoses, or even if they don't and they don't feel well supported, I refer them to the naturopathic oncologist that's here in my town that I live in.
Mhm.
And he does wonderful work. I absolutely have absolute trust in him for sure. So I just don't even hesitate. It's just something it'd be the first call I'd make if it was my own experience. So let's get tactical a little bit here for the woman listening that may be experiencing breast cancer, or maybe she's had it in the past and it's in remission. What does it look like to go see a naturopathic oncologist?
So I can only really speak from my own experience, right? And I really feel that the best opportunities start at the time of diagnosis. And when a woman is diagnosed with breast cancer, she enters into what I call the breast cancer industrial complex, um, which
Wow, you're not
which
wrong.
is a fast, overwhelming speed train taking her from holy shit, something was on my screening mammogram, to, oh my God, I've got breast cancer and they want me to have surgery next week, right? So it's this incredibly overwhelming, difficult time. And women need to have a lot of information to be empowered to make informed decisions. And in an ideal world, they'd be getting as much information as possible to make informed decisions from their conventional providers. And in some cases, it's a crapshoot. I mean, I've been fortunate enough to work with world-class providers in the Seattle area and in the Bellingham area, which is where I am now. And, a lot of really knowledgeable, caring individuals, but they don't always have a lot of time with the patients. And not all of them are going to necessarily drill down in ways that are going to ease a woman's anxiety, right?
Mhm.
And so, from the start, I like to help women make really good informed decisions so that they understand what their risks are and what the benefits are of the different therapies being offered to them. But I also, and I don't treat people in a protocol kind of way, but there are phases to what happens during active treatment for breast cancer, right? There's this diagnostic phase, there's often a surgery phase, often a chemotherapy phase, but not for sure, and often a radiation phase. And then there's, for a lot of women, anti-estrogen therapy, and then there's the rest of their lives, right? So there are all these different chunks, and I try really hard to slow people down and say, let's just focus on this little piece,
Yeah. Oh, yeah.
because the little piece is enough, right? And my recommendations are different for each little piece that a woman is going through,
Mhm.
and there's such a misconception about cancer that all cancers are all treated in the same way. And oh, my Aunt Lucy did chemotherapy, and so I don't want to do chemotherapy. And it's like, do you know how many chemotherapies there are? They're like
Mhm.
hundreds of
Yeah.
chemotherapies, right?
Yeah.
But it's also, you know, an individual and her individual pathology report and the behavior of the cancer and the recommendations and her other, sort of health issues. There are so many layers and,
Mm.
genetics and genomics and all these kinds of things, right? So each woman is such an individual and has such an individual case of breast cancer that it's not just breast cancer.
Mhm.
It's her breast cancer and what's going to be right for her, right?
And I think that is such that lens that you just shared is such a game changer for this is what I imagine to be a game changer because and maybe this is the as you called it the breast cancer industrial complex. That's so funny. I'm
Yeah,
forever going to be calling it that and I will refer to you as the
it is.
originator.
It's absolutely, it's a big, scary, corporate
Yep.
money-making machine.
Yes, and it has a marketing department with
Oh,
pink
yeah.
ribbons, you guys.
Oh, fuck the pink ribbons. I mean,
Yes.
just take those off.
No, stop putting money towards the pink ribbon stuff, you
Yeah.
guys. Stop
Mm-hmm.
doing. There are better ways to donate directly to people that are experiencing this.
Yeah.
Please understand that the reason why Dr. Laura and I are saying this is because we know that the money that goes to the pink ribbon campaigns pay for science that is never ending. It's a perpetual thing. And they don't want to find a cure. If they find a cure, this shuts down a multi-billion-dollar industry.
Well, but it's also, I mean, the pink ribbons are pink washing, right?
Yeah.
So different companies think, oh, it's October, it's breast cancer
Yeah.
month, and I'm gonna, put pink ribbons on all my marketing materials and say, hey, let's fight this thing. And there's so much wrong with that.
Mhm.
Not just the marketing and the corporatization of it, but the constant battle language, the constant sort of faux cheerleading,
Mhm.
right? I mean, that's really what it is. It's faux cheerleading. Breast cancer fucking sucks.
Yeah.
No matter what stage you have or what experience you're going to have from a treatment perspective, it sucks and it affects every single aspect of a woman's life.
Mhm.
Breast cancer is a feminist issue. It affects not just the medical aspect, but psycho-emotional state,
Mhm.
spiritual state, existential crisis
Yeah.
state, relationships, workplace, children, finances. I
Mhm.
mean, you name it, breast cancer affects that. And women, so much of what I try and do with my patients is let them have the conversations that they
Yes.
need to have that nobody else is letting them have because the constant message is fight, 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 team, win, pink, right?
Yes.
And
Yeah.
go pink. And it's like they're feeling crappy, they're
Mhm.
scared,
Yes.
they're grieving the loss of a breast and maybe their sex life with their spouse.
Mhm.
They can't get through the day. I mean, like, these are real concerns.
Mhm.
And for women who have metastatic disease,
Mhm.
metastatic breast cancer, where it's spread, these are their concerns every day
Yeah.
for years,
Yeah. Yeah. Yeah.
right? It's
So
like
let's
pink isn't enough.
no, absolutely not. Absolutely not. Okay, so
Changing women's rights would be maybe enough.
yes, yes. I Oh, that's such a statement. Oh, Fiona, just keep it on track over here. Laura, the truth is I want to go off into that zone, but again, let's
You'll just
that
have
might
to have me back. Just like
I
make notes.
absolutely. We're definitely gonna have that shit disturbing conversation. Anyways, my listeners are well aware of my nature to ask the provocative things, so it's totally
Good, good.
totally the way it should be. Okay, so you mentioned a few things that I want to pick up on. So, what's the difference between breast cancer and metastatic breast cancer?
So they're both breast cancer.
Mhm.
But breast cancer is staged from stage 0 through stage 4. And stage 4 is metastatic breast cancer. Stage 0 is ductal carcinoma in situ. So DCIS, many women are diagnosed with DCIS. It is stage 0, and at a cellular level, it is an encapsulated little area of tumor cells that generally can be removed with a very simple surgery called a lumpectomy.
Okay.
Um, Stage 1 through stage 3 has to do with those cancer cells escaping that little capsule and maybe traveling to lymph nodes. So getting bigger, traveling to lymph nodes. When it's a stage 4 breast cancer, there are breast cancer cells in the bones or the lungs or the liver or the brain, or all four of those, in addition to the original tumor site. So when a woman has her initial evaluation, she will learn what stage disease she has. That's part of the initial diagnostic process, and treatment is recommended based on stage and other factors of somebody's pathology report. So,
Okay. Okay. Well, I think one of the things that happens, I've certainly seen this happen, is and as to quote you again, the breast cancer industrial complex says, "Oh my God, get it out! Rush, 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 get it out."
mhm.
And I think that we would be well served to help pause and gather resources. And I'd love to hear what you say about that. And I think the naturopathic oncologist should be part of that.
I think we should be too. I mean, I really feel that women do well who have an integrative plan, who are working both with a conventional team and an integrative team and sort of have the whole thing. But I know
Mhm.
that that's not available for a lot of women around both of our countries, right?
Yeah, yeah.
Surgery is an interesting question, and surgery actually can be extremely helpful, but making the choice about the correct surgery can take a little bit of time. So I agree in terms of pausing regarding choosing the right surgery, but most of the time, surgery is a really good choice. And I think about the percentages of benefit of conventional care. So when a woman has her diagnosis and she's talking with her conventional team, she'll be presented with percentages of benefit. At least if her team is sort of on the ball, she'll be presented with percentages of benefit of each step of standard of care treatment that she receives. And surgery can reduce her risk of secondary recurrence, which is at the start of diagnosis. This is what we want to do. What are the things we can do to prevent it from coming back, right? Surgery can actually prevent secondary recurrence by up to 50%. So it's an enormous percentage. Get that tumor out, there's nothing growing in there anymore, or at least we hope there's nothing growing in there anymore, right?
Yeah.
The percentages of benefit, the percentages added to that continuum of how much can a woman do to prevent secondary recurrence. Chemotherapy is a smaller margin of benefit. Radiation is a smaller margin of benefit. None of those numbers take into account integrative therapies, unfortunately. I believe, and there are a few studies, but I believe women who do integrative therapies get better return on their investment with those percentages in terms of preventing recurrence. But, surgery's often a really good choice. Chemotherapy, radiation, you really want to think about those and have deep conversations with your providers about what's the percentage of benefit.
And this is what you do as the naturopathic oncologist, is have those conversations. Yes.
That's part of what I do. There's a lot more power in the conventional oncologists because they can order a whole lot of fancy tests that help to determine some of that information. So it ends up being kind of a team effort. But I want women to be aware of all of these pieces to the puzzle, right?
Yeah, absolutely.
There's no given, right? Once a woman is diagnosed, there's no given. There's a lot of variation, there's a lot to discuss, there's a lot to decide upon, right?
And you can act as that advocate and person to discuss with, along with the traditional oncologist, which is, so often we get 5 minutes with the doctor and we want to ask 10,000 questions and we get to ask two,
Right.
and
Exactly.
then we get put off to the nurse.
And it really helps women to have a buddy for all of their appointments because she's in a fight or flight mode. She's not necessarily going to hear everything that her provider is saying. And so having a buddy who can listen and take notes is really, really helpful. And I often have like whole families in my office, and so it's a team effort. And not only does a woman have to choose and trust her medical team, her conventional team, her integrative providers, her entire integrative oncology team, she can choose those people and hopefully she trusts them in that process. But she also can choose her home support team. And it may not be the spouse, it may not be the sister, it may be the friend, it may be the neighbor, it's going to be whoever it's going to be, right? So, and that's also one of the things I talk to women about early is, can you figure out what you think you're going to need and how to ask for that? Because you can't do this alone. You have to have support. And you have to be able to ask for what you need, not what you think people think you need. Right?
Wow. That's a powerful statement. The buddy system. Yeah, I'm just pausing because it feels very emotional to hear that. And as you and I talked about when before we started the recording, there's a sisterhood here, and we were always meant to support each other.
Mhm.
And we've been driven apart by, various forces. But I don't know if you can feel this, but I can certainly feel us coming back together.
Yeah. I think, breast cancer or any cancer really. I just work in the breast cancer space, but breast cancer is a life-defining moment for women, right?
Mhm.
It throws all of their beliefs into relief, right? And tests all of these aspects of her life, which are extremely difficult for women, right? We hold up the world,
Oh, yeah, we
right?
do. Oh,
And
yeah.
who's going to hold us up when we have a striking diagnosis, right? You want to choose those people. You want to ask those people, and people want to help, right? But
Yeah.
it's better if you tell them how you want them to help you.
Yes.
It's not always like bring me another tuna casserole. It's like, will you come over and do my laundry and fold it for me because I'm too tired to
Oh,
do it myself, right?
yes.
And sometimes it takes writing these things down and like having a conversation with your best friend or whatever. And we're so worried as women. We're so worried about what other people think.
Yeah.
And we're so worried about being a burden for other people.
Hmm.
And we carry everybody else's burden,
Yeah,
right?
we do.
We're like,
Yeah,
oh,
we
no
do.
big deal,
Yeah.
right? I'll carry that burden, right? But we have to find our own self-compassion and give ourselves grace in
Which
this, in a diagnosis like breast cancer. We need to all do it.
oh, yeah, absolutely. And I was
We
just
need to
thinking,
all do it. And it's like,
yes.
why the fuck does it take a diagnosis
Yep.
like breast cancer, which like
It's good.
shakes the very foundation of someone's life, to
Yes.
be able to find their worth and say, I'm going to talk to myself the way I talk to my best friend, which is with
Yes.
compassion and love,
It's
right?
conditioning. All of this is
It is.
conditioning,
It's
right?
conditioning.
We
Yeah.
are conditioned to take care of others before ourselves. And when we have our
Mhm.
own diagnosis, it feels so terribly inconvenient and shameful
Mhm.
that we don't ask for the help. So, in that way, this is, I think, another place where, again, the sisterhood steps in. And by the way, if any of my friends are listening, for God's sakes, ask me to come and do your laundry. I'm such a dork about laundry. I fucking love it, but don't ask me to make you a tuna casserole. Babe, I'm there. You want me to do your makeup? I'm there. You want me to fold your knickers? I'm there.
Funny. One of the things I love about working with patients who have cancer is like, I enjoy having these vulnerable conversations with people. Like and I do it with my friends too. And it's amazing I have as many friends as I do because they're always like, oh my God, you're so intense.
Here she
Um,
goes. Are you
but
a Scorpio?
no, I'm not. I'm an Aquarius.
Ah,
Um,
okay. The
but
next guess.
but I'm not phased by having these really intense conversations with people about real things,
Yep.
right? And, I want to be able to provide a space for women to feel comfortable to talk about the things that are really bothering them. The medicine is one thing. I can run labs, I can prescribe shit, I can do all that stuff.
Yep.
But honestly, 75% of medicine is listening
Yes.
and bearing witness,
Yes. Yes. Absolutely. Eyeball
right?
to eyeball, knee to knee.
Bearing witness.
Mm-hmm.
And there's so many aspects about having breast cancer that just aren't addressed in the day-to-day standard of care kind of marketplace, and a lot of people don't like groups. I mean, I think groups can be very beneficial, but they can also really bring people down, and it depends on how the group is structured.
Mm-hmm.
But it's like, don't just refer your patient to a therapist, like it's not just about therapy, right? It's about human connection and
Yes.
human need and grief.
Yes. Great.
And there's grief
Yeah.
like about all these things,
Yeah.
like everything. There can be
Yep.
grief about everything.
I can absolutely imagine that. So tell me, do you find the Western medicine doctors that are treating your patients want to collaborate with you?
I was on a podcast last week. They asked me the same question. Sometimes I have had good fortune in my career to work with some providers who really get it, and who are really supportive, regarding their patients having an integrative plan. Most oncologists I run into of all different types, whether they're, surgical oncologists, radiation, or medical oncologists, are sort of grudgingly tolerant because they recognize their patients are going to seek all these things out anyway.
Mhm.
And, I try and make myself as transparent as possible and as open as possible. And I write extremely thorough chart notes. And it's rare that one of these sort of grudgingly tolerant providers actually reaches out to me for information.
Mhm.
But the folks that I've had good relationships with over the years, and I've had great relationships. These are like texting relationships, right? Where there's
Nice.
like immediate feedback kind of information.
Amazing.
Those are great. Those are really, really great. But, it's a belief system, right?
Mhm.
And you either have to believe in holistic medicine and treating the whole person, or you have to believe in siloed medicine that's restricted by both science and institutions.
Okay, I'm going to ask the big question, which I think you will absolutely be fine with. You strike me as the person that can handle this question. You just said belief system. And so, what I heard, and let me explain for the listeners, medicine is a system of beliefs that say A plus B equals C. And this is how we teach the doctors. And there's a siloed sort of effect. Only the thyroid people deal with thyroid. That's not a very good example. Only the cancer people deal with cancer. Only the OBGYNs deal with women's health, but basically only until menopause. And then after that, nobody was looking at that. And it's a learned system of paternalism and patriarchy. So, the big question, actually, it's not even a question. I'd just love to hear your thoughts on that, please, because you and I work with the people that are aware enough to know there is something other than that.
Mhm.
Go.
The first thing that comes to mind is the number of female providers that I have met in my career who are more patriarchal in the way they practice medicine than some of the men I've run into. And I mean, we know that women now make up the bigger numbers in terms of who's going to medical school and who's graduating.
Mhm.
There are a lot more female providers, right? Um, it is a patriarchal system. It is a
Mhm.
top-down system. And, we're still dealing with doctors and patients who see the white coat, right? And the white coat is God, right? And, I think it's going to take a long time for us to shift away from that.
Mhm.
Um, and it is very much a belief system. It's the allopathic belief system of how medicine works. I don't think that there's any debate about how the body works,
Mhm.
how the physiology works and how that science works. But, I think there may never be enough inquiry
Mhm.
into, like, let's say, plant medicine, which
Mhm.
also includes how food is
Mhm.
sort of physiologically active in the body, but plant medicine, which can be multifactorial, right, as opposed to this linear targeted pharmaceutical kind of medicine, because plants are plants and not able to be patented.
Mhm.
We're not going to get the kind of science that's really going to look at how a plant like Siberian ginseng has so many different adaptogenic actions in the body, right?
Mm-hmm.
And we're also, it's also very, I said linear, but also very dependent on what can be seen, right?
Mm-hmm.
As opposed to what we might know.
Mm-hmm.
And I think one thing that happens to, I think this happens to a lot of people, not just women, I think also to male providers. Um, we get our intuition beaten out of us
Mm-hmm.
in the school process,
Yep.
right?
Yep.
And and in
It's
so many,
replaced with a judgment system, is it
it's
not?
replaced with a judgment system. Oh, I just remembered what I want to talk about, and I'm writing it down.
Okay, but we
Okay,
got to come back to judgment
okay, we're
system
gonna come
because
back
it's
to
good.
that.
Okay, good.
Thank you. You just spurred my memory on that one. The, our intuitions are beaten out of us, and our respect for the energetics of medicine
Mm-hmm.
are also, just kind of poo-pooed,
Mm-hmm.
right?
Mm-hmm.
Um, and I think that, like I said, 75% of medicine is listening and bearing witness.
Yeah. Yeah.
There is such an energetic and intuitive piece that
Oh
goes
yeah.
into
Mm-hmm.
the art of
Mm-hmm.
medicine,
Mm-hmm.
right?
Mm-hmm.
And, hardcore scientists can call that the placebo effect, right? But it's part of the medicine.
It is
It's
part of the
really part of
medicine.
the medicine.
It's a big part.
And but I think also that we're shooting ourselves in the feet by siloing our medicine.
Mm-hmm.
We're siloing it, and it's kind of like the same process of, from cow to hamburger, right? Like just hold on with me here. From
Okay.
cow to hamburger, you get, cow, we're talking industrial cow, cow ultimately goes to slaughter, gets like wrapped up, whatever, ultimately is like over here, and then you've got like a hamburger on your plate, right? It's this whole big process of processed food, right? And in many ways, it's the same thing in conventional medicine,
Mm-hmm.
is the individual patient is so far away from having relationships with providers who maybe really understand that patient,
Mm-hmm.
right? Like
Mm-hmm.
the primary care physician, who
Mm-hmm.
shouldn't just be a gatekeeper,
Mm-hmm.
and that's really all they do now,
Yeah.
right?
Yeah.
The primary care physician who maybe delivered that baby,
Mm-hmm.
who is now seeing that patient through adulthood, right?
Mm-hmm. Mm-hmm.
And and there's so much holism there that we've lost, because patients enter the breast cancer industrial process, complex, and they're processed, and they come out the other side with a new boob
Right. Or one boob or
or one boob. Yeah.
yes, exactly.
It's a
This is
commodification of the medicine.
yes. Yes, yes. I was
Yeah.
just going to say this is when you hear the term protocolization of medicine, this is what we're talking about.
Yeah.
And to give you an example, I'm going to talk about a family member who recently had heart surgery, had a bypass for blockage. And he was given a pile of meds after that, as you are, and as the research shows, as the protocol shows. And about 2 months or something after the bypass surgery, he developed retinal bleeding. And so that was treated. But when he spoke to the cardiologist about it, the cardiologist said, oops, that's a medication you should have never been on because you didn't have a stent, you had a cabbage, which is the bypass surgery. Of course, you know
Mhm.
that. And I remember going, what the fuck? Is anybody actually doing this properly?
Mhm.
Like, how? And so now he has months later, he still has visual deficit that the retinologist said it may go away, it may not, because he developed a bleed in his eye. because of an anticoagulant therapy that he never should have been put on in the first place because he didn't have a stent. He had bypass surgery. So this is what we're talking about. That's a real a real example of where protocolized medicine is a problem, and it's done, from my understanding, because it's an efficiency. I think is what I understand it to be.
Well, and this is why we don't have major, well, it's one of the reasons why we don't have major integrative oncology programs in the US is because it doesn't pay. It doesn't pay to have a provider spend an hour and 15 minutes with their patient, talking about all the things, right?
Mm-hmm.
And yes, I mean, there's such a disconnect, and it really it's a disconnect that every single naturopathic or medical provider I know experiences.
Mm.
We get into medicine thinking we're going to help people, and we get bogged down by everything we have to do to cover our asses. It's
Yeah.
legal, right? It's legal.
Mm-hmm.
And there's a very good reason for all of that legality to be in there for the most part. But so much of what we have to do was created because of some negative legal outcome that happened in the past and set precedent, right?
Mm-hmm.
So we were forced to follow protocolized medicine
Mm-hmm.
because of the lawyers, not because of the individual that's sitting in front of us. And I mean, I went to a retreat 2 years ago
Mm-hmm.
that was actually sponsored by a major medical organization in my community. And it was a 3-day retreat for burned out female healthcare providers. That was like almost the title, it was sort of like blah, blah, blah retreat, for burned out female healthcare providers, I mean, that was pretty much what it was.
Yep.
And it was a time for me where I was contemplating taking maybe a sabbatical, maybe walking away from practicing completely.
Mm-hmm.
And it helped me make the choice that I was going to take a sabbatical for a while. But we're burned out.
Yeah.
We're so burned out, right? And naturopathic doctors are burned out too, because we are trying to fix the chronic shortcomings of conventional medicine.
Yep.
Right?
Yep. And think about the professional females that are in medicine, whether it's traditional medicine, Western medicine, or alternative or natural medicine.
Right.
Do I know anybody who's continued to practice without a health crisis? Now I'm talking about women. Without a health crisis or a need for a sabbatical or a leave or a burnout period, especially after COVID. Oh my God.
Right.
There isn't a single one. I can't think of a single one.
Right. Exactly.
The other thing that I think is really interesting is so many of the women I went to professional school with have autoimmune disease.
That's interesting.
Isn't it though?
That is very interesting. Yeah.
I think so too. Yeah. I just had a patient interaction on Tuesday this week with an RN of 40 years who talked about what she's seen in her time and how she's moving to a totally different area of medicine because she's treated adult cancer patients for most of that time. And she said, I'm moving to a totally different area so that I can stay passionate about what I see.
Yeah.
So I think this is a real issue.
I think a sabbatical, if people can take a sabbatical, I mean, it took me 6 months to unwind. Oof. And it took me a full year to feel like I was ready to see patients again. It's real. The burnout is real.
Menopause skin. Nobody's favorite part of the transition at midlife we call peri-menopause and menopause. If you're noticing fine lines, wrinkles, or sagging skin, maybe more texture during your menopause, I have some really exciting news for you. Menopause can deplete your skin's collagen, speeding up the aging. But here's the news. Vitali Skincare has built its entire line on the power of GHK-Cu copper peptides, a proven ingredient that signals your skin's stem cells to produce new and healthy collagen. My personal favorite, Vitali's Restorative Skin Cell Serum. I love how it rejuvenates and restores my skin from within, revealing a firmer, more radiant glow. Want to experience this transformation for yourself? Head to vitaliskincare.com and use the code LOVELY at checkout for 20% off. That's vitaliskincare.com, VITALI skin, SKINCARE.com, code LOVELY. Because with Vitali, youthful, vibrant skin is just a step away at any age.
Do you know who the Nagoski sisters are?
Of course.
The authors?
Yes.
Yeah.
Yes.
So, I mean, there's the Emily Nagoski's book, Burnout, which is excellent. And there's a workshop or a workbook that goes with that.
So
and her sister, can't remember her sister's name, but the sex books are amazing.
Yes, the sex books are fantastic. It's Emily and
I can't remember, but
keep talking. I'm going to look.
They're
it
like
up.
a powerhouse author family.
Yes. Right.
All right. So my note that I wrote down, shame. You brought up shame. In the context of being a burden emotionally when you have a diagnosis. And my train of thought.
Emily and Amelia. Sorry.
Emily and Amelia. Right. Right. Yeah. Read them. Tell your reader, tell your listeners, read them.
Oh, yeah. Yes, absolutely.
You brought up shame in the context of being an emotional burden while you have cancer. One of the things that is really, really important for women to understand in the breast cancer world, if they're diagnosed with any cancer at all, it's not her fault.
Oh, yeah. Yeah.
There is nothing, there is no thing that a woman has done that gave her cancer.
Yeah.
Cancer is so complex and there is so much out of a woman's control. There are so many layers of influence. And I've had, it's not every patient, but I've had enough patients come in and say, what did I do to get myself here? And I'm like, no, please do not think that way. It is not your fault. Do not have shame for having cancer. Right? And that's a really big thing for people.
Huge.
Really
I bet
big.
you see them melt right down when you say that.
I don't know. I mean, some people have really hard shells, Some people have really hard shells, but I just try to be real. I try to be real. Unfortunately, I say what I think maybe too much. And I'm one of those people who can talk about really hard things without like breaking down in tears most of the time. I can be very clinical about all of these things. And I often have to like reel that in,
Yes.
I
do know. I know exactly what you're talking about. I'm that way too.
Right? I'm like, why can't you talk about your existential crisis for Christ's sake?
I mean, if you talk about it, then you won't be stuck
about it.
Yeah, exactly. You won't be stuck in therapy for the next 20 years. Talk about it. I know. I'm the same way.
So yeah, I just wanted to say that because you brought up the notion of shame, and it's an important point.
Yeah, I like that. Okay, so let's talk a little bit, please, about there's all of these sort of terms that go along with breast cancer, like estrogen receptor positive or BRCA or the HER thing. Like, can we talk about those? What do they actually mean, please?
Sure. So 70% of breast cancer diagnoses are of tumors that have either estrogen receptors, progesterone receptors, or both. those are considered the hormonal cancers. Estrogen, progesterone receptors will receive those hormones, and breast cancer tumors can grow using those hormones as fuel. Women who have hormone sensitive cancers will be recommended anti-hormonal therapy down the road. Okay. HER2/neu positive cancers. HER2/neu is a different receptor. Those three receptors, estrogen, progesterone, and HER2/neu, are the tumor cells are tested for those receptors because that's some of the most important information that you could get in the diagnostic process. HER2/neu cancers that are positive, there are certain drugs that target HER2/neu cancers that target that receptor that are pretty effective. We have those now in the last 20 years or so. And so in both cases, there are drugs that can be used, right? So 70% are ER/PR positive, up to 15% are HER2 positive. I can't remember the exact percentage, but it's a smaller percentage that are all three positive. So some breast tumors have ER/PR HER2, and some breast cancers have none of those receptors. And those are called triple negative breast cancers. So that's the receptor picture. And knowing the receptor status is important from a treatment perspective, right? Different drugs.
And this is one of the things I think is most misunderstood about a breast cancer diagnosis by the doctors as well as the patients, is that if you have these receptors positive, does it mean that you can't do HRT?
That's not where I thought you were going, and that's a loaded question.
I know it is a little
Loaded
bit.
question.
Can you answer it?
I can absolutely answer it,
Okay.
but I want to finish just explaining some of the
Please.
terminology you brought up first, and then
Please.
I'll go there.
You got it.
So there's receptor status, which is really important, and then there's genetic status. Because you brought up BRCA1 and BRCA2, those are the most famous oncogenes that increase a woman's risk of breast cancer. There are other oncogenes that can be tested for that increase your risk of breast cancer, but only 7 to 10% of breast cancers are genetic.
Interesting.
So that means 90 to 93% of breast cancers, the majority of breast cancers, there is no genetic link that we can find.
Okay.
This is what makes it so complex. Okay. All right. So the HRT question, it's a sensitive question. It really is. And conventional wisdom is for a woman who has an estrogen receptor positive, progesterone receptor positive breast tumor to have all estrogen and progesterone removed from her system, in some cases going as far as having her ovaries removed to reduce the estrogen, to reduce the hormonal burden on the body. Drugs are given to reduce the hormonal burden on the body. Unfortunately, we know, and you as a menopausal specialist, that estrogen in particular is really, really good for us, right? Estrogen nourishes the bones, nourishes the skin, nourishes the bladder, nourishes the brain, nourishes, everything in a woman's body. And having a breast cancer history, unfortunately, in 99% of medical circles, will not allow a woman to have any kind of hormonal recommendation. The only one that most medical oncologists I've worked with over the years feel comfortable with is vaginal estrogen, because there isn't systemic absorption from using vaginal estrogen in the way there is from taking oral or using a patch. And so vaginal estrogen usually is allowable. Women with triple negative disease, it's a different story. They don't have those receptors on their tumors. Sometimes their oncological teams are very conservative and won't let them have any estrogen either. There are cases where tumor cells develop receptors. So, like I said, breast cancer is an extremely complex disease. I feel very comfortable recommending vaginal hormones for patients all the time. It's a quality of
Mhm.
life issue.
Uh-huh. Yeah.
Systemic hormone replacement is a much more difficult question.
Mhm.
The literature really does show that there is no increased risk of recurrence in women who've had an ER-positive breast cancer who go back on hormone replacement therapy after they've been diagnosed.
Can you say that again, please?
Maybe.
Okay.
The
What is
literature
Yeah.
really does show
Yes.
that in terms of patient incidence of recurrence after breast cancer diagnosis,
Mhm.
that being on hormone replacement therapy, and I'm talking only bioidentical hormone replacement therapy
Mhm.
because the rest of it is shit,
Yeah.
that the hormone replacement therapy does not increase the risk of recurrence
Yes.
in
Okay.
that population.
Great.
But find me a medical oncologist outside of Ira Blooming at
Mhm.
UCLA
Yeah.
who will actually prescribe
Yeah.
systemic hormone replacement therapy for the women who have had breast cancer. Find me that medical
I
oncologist
I
in
know that.
either of our countries.
Exactly, they're hard to find. So, of course, what Dr. Laura is referring to is the Estrogen Matters from Doctors Avram Blooming and Carol Tavris. And I was just listening to him in an interview earlier this week, and of course, the story behind that book is that he is an oncologist, and his wife was going through breast cancer and having such terrible menopausal symptoms. She was asking him, can I take something for these symptoms, hot flashes and that sort of thing? And he said, well, the answer is no, but is it really? Like, and he said, well, wait a minute, I've got the skills and the ability to review the research and find out whether or not it's actually okay for my wife to take these things. And of course, what he found was that the research showed overwhelmingly that HRT is safe for
Yeah,
women who have experienced breast cancer.
yeah,
And if you have a doctor that is resistant, I say take the doctor the book, right? Well,
yeah,
doctors don't have time to read the book, but at least the point is made. The point is
yeah.
made. And so
I
the
think,
the book is the compilation of the research that shows it's safe.
yeah,
Go on.
I think though, I made a comment earlier, I made several comments about the breast cancer industrial complex,
Mm,
but institutional protocol protocolization or processing, there really is institutional bias.
mm,
And, it's you get maybe the lone medical oncologist in a system who understands the research and can think for himself and
mhm,
will want to prescribe hormone replacement therapy for the patient who has severe menopausal symptoms post breast cancer treatment. He will be vilified,
yeah.
right? He will be ostracized from his community, right? So,
Mhm.
I mean, we're still at this sort of like witch hunting kind of place
Yes.
with this
Hmm.
kind of medicine. But number one, conversations with patients are private. Number two, quality of life is extremely important, particularly after you've looked down the barrel of breast cancer
Hmm.
and your body has changed and your brain has changed and your boobs have changed and all
Hmm.
these things have changed. And maybe you have osteoporosis and
Hmm.
you've already taken, whatever, Fosamax or whatever.
Yep.
Or maybe, here's a case that I had of a woman who had a stage 3 breast cancer. So, stage 3, larger tumor size, nodal involvement. She did as much conventional treatment as she could. She was like 45 at diagnosis. She was in her mid 40s. And unfortunately, she also had osteoporosis and she was young to have
Hmm.
osteoporosis. And she was a patient of mine for a long time. And at like 57, She's like, Dr. Laura, can I take hormone replacement therapy? And we had this conversation. And another provider had actually, another naturopath had actually prescribed it for her, but she wanted to run it by me. And I was like, but it was a what's the bigger
Yep.
problem here,
Yep.
right? What is the bigger problem? She'd already broken a hip
Hmm.
and had a repair, and she was an
Hmm.
extremely active person. And
Hmm.
so I'm like, yeah,
Wow.
let's
Yeah.
save your bones
Yes.
and take our chances on a breast cancer recurrence.
Yes.
Right? I mean, because
Absolutely.
when you think of the four horsemen of the apocalypse, right? You think of cancer, dementia,
Heart disease.
osteoporosis,
Yep.
actually heart
Heart
disease, but I
disease.
put
Yep.
osteoporosis in there,
Yep.
and diabetes,
Yep.
right?
Hmm.
What's the bigger thing that's going to kill you? And I tell women this all the time. Heart disease is what's going to kill you, not the
Yeah.
breast cancer.
That's right. That's right. And I think having the big picture conversation and you and I having this discussion is going to bring awareness in a lot of ways that if a woman is having traditional treatment for cancer, whether it's breast cancer or another kind of cancer, um, it the conversation needs to consider, as you said, the quality of life issue. So, as Dr. Blooming has taught me through the book and through his interviews, women experiencing breast cancer, 90% or better will survive. So, you're 7 times more likely to be taken out by heart disease than you are by breast cancer. So, if you have a lot of heart disease in the family, you're starting to show signs of heart disease, but you've been through breast cancer and your provider is not affording you the protection of the heart that comes with taking estrogen. Let's just say HRT, because we don't know that much about testosterone is really important there too. Progesterone is important there too, but we know less about those because there just haven't been the studies, etc. And we need to look at that whole landscape and say, maybe there's a chance that I could have a reoccurrence of a breast tumor, or I can spend the next 40 years if I make it that long, or maybe I won't make it that long because I've got heart disease brewing, right? You really have to look at it and say, what weighing the pros and cons of it.
Right. And this is going back to the beginning of our conversation about informed decision making. It's my body, my choice.
Mhm.
And, there are a lot of decisions along those lines, right?
Yeah.
And, cancer is the big C, right? Cancer is spelled with a capital C. Heart
Mhm.
disease, diabetes, those things aren't necessarily spelled with capital letter. And people know when they hear those things, oh, I got to change my diet and my lifestyle, right? Cancer, they're like, I want to do everything I can to never get cancer again. I'm like, you got to change your diet and your lifestyle.
Yeah.
And so, we're changing the whole playing field by doing that, right? We're mitigating the heart disease and the diabetes conversations, right?
Yeah. Yeah.
So, yeah, I mean, I like to think of myself as someone who is creative and trying to think about the big picture and trying to meet people where they're at. Um, I don't have all the answers, you know. I just do my best
That's
and
all.
and give people a space to ask their questions and not make them feel stupid, you know.
Hmm. Hmm. I love that. What you've said several times about medicine being 75%, what did you say, perception?
75% listening
Witness, right.
and
Yes,
bearing
yes,
witness. Yeah, I'm just bearing
absolutely.
witness.
And
Yeah.
the other 2,500% is paperwork, just so everybody knows.
Yeah, right. Exactly. Mhm.
Oh, that's girl math for you right there.
Yep. Hmm.
Anyways, what are you most hopeful about when it comes to breast cancer, treating women with breast cancer, where you see medicine going with this?
I mean, breast cancer really is a cancer that does have a lot of answers. Like you just said, 90% of women can have at least some level of um, cure, right? I mean, not everybody's cured, but And I guess in some ways we have to kind of thank the pink ribbon, army for doing a lot of research, right? And for finding out a lot about breast cancer. Um, I think having more answers about its origin would be extremely helpful. I do think we have a lot of really good treatments, and I think if we had investment in looking at how an integrative program really makes those treatments work better, um, we'd have, just better information and sort of more ammunition for the idea of having integrative programs everywhere. But I think that we know some about oncogenes that increase the risk of breast cancer if they're turned on. I think we're going to find out more information about other genetic material that human beings have, particularly related to how the liver detoxifies and how the kidney detoxifies. We're under such a tremendous environmental burden of pollutions, pollutants and microplastics and stuff like that. I'm hoping to see our testing get better with all of those things. And I'm also hoping for, sort of some science around those aspects of the human experience that are influencing carcinogenesis. I mean, because our incidence of cancers is high and younger people are being diagnosed. I mean, there's got to be a reason, right?
Mhm.
Um, and the testing we have for microplastics is rudimentary at best.
Mhm.
There is some testing where we can take a look at detoxification pathways, but I talked to one of my conventional oncology friends and they'd be like, oh, it's not ready for prime time. And I'm like, well, that's why I'm a naturopath, because I'm going to use it anyway, right?
Yes. Yes.
Because this makes sense.
Yes.
Um, right. So, um, I've been practicing for 25 years. I've been in this space for like 30, and I think we have to look at the whole cancer patient. It's not just the receptor status, and it's not just the breast. It's the whole woman.
Yeah. Oof, that's a big one. Well, thank you for dispensing this wisdom today. I have very much enjoyed this conversation.
Thank you for having me and letting me be sort of like unhinged.
Please.
Just open my brain. All right, there we go.
The unhinged conversations are my favorite.
Maybe unhinged isn't the right word. Maybe unbridled is the word
Yes,
I want.
unbridled. I like
Yeah,
that one too. The
unbridled.
freeness of this
Because I'm definitely
conversation.
not unhinged.
No, no,
I'm
no, no,
very
no.
hinged.
You're even though some days I think the world would be easier to manage if we were a little less
We were
aware.
a little
Yeah,
less
yeah,
aware. I know, right?
yes.
Oh, man.
So can people who are experiencing women who are experiencing breast cancer, can they get in touch with you? Are you taking patients at this time? Can you tell us a little bit about how people can find out more about you,
Sure.
please?
Yeah, so I don't have a conventional practice anymore, but I do consult people. I do virtual consultations at this point. And I can consult anybody. There's an application process on my website, laurajamesnd.com. I also have a very comprehensive Facing Your First Year of Breast Cancer program. And it's a self-study program. There's 8 hours of material in it. So it's really comprehensive and it lays out everything that a woman needs to think about from the time of diagnosis through her active treatment. And I actually provide monthly Q&A touch points in a group setting for 12 months with that program.
Amazing.
So overall, I think it's a lot less expensive for people to do that program because they get a lot of information. They can go back to any updates I make to the modules, they'll get automatically. And then there are these touch points where they can ask me some questions, but it's not case management. Taking patients where I'm actually managing cases, I sort of fewer and farther between these days.
Mhm.
I do run survivorship programs periodically, and those are group programs and those are interactive group programs. I don't have one coming up right now because it's the holidays. I do a whole bunch of podcasts and public speaking and stuff like that. And I also have a newsletter. The newsletter is totally free. People can go to my website and sign up for the newsletter, and that comes out every month. And I also have a small supplement line, products under the brand Best for Breast. I have a hot flash relief formula called Flash Relief. And then I have a product called Terrain Defense, which is a whole bunch of terrific natural compounds that help prevent secondary recurrence. So people can
And where
check
can
us
people
out,
find those?
bestforbreast.com. But it's
Okay.
also, there's information on my main website.
About them.
Um,
Okay.
so yeah, so
Amazing.
that's what I got right now.
Amazing. I love it. I love it. I think our conversation today will bring a lot of fresh awareness to women in a way that's helpful. And I want to ask you the last question I ask all my guests, if I may. In fact, I think I'm going to ask you two, which I haven't done in a while. So there you
Okay.
go. You're like, the pressure's on. Okay. I am aware that in other countries, there are accommodations for women for anything from postpartum to menstrual disorders, etc., where you can get paid time off. And I happen to live in a country where we give women a 12-month maternity leave. Actually, the fathers can take it as well. Um, and I envision a time where we can do a menopause leave, and our government subsidizes our lifestyle, our income. Well, we can take a year to do whatever we feel like we need to be well. And a woman can take it at any point during the perimenopause years, or frankly, any time after, let's say, 45. So if you were afforded that and the government gave you a bursary to choose practitioners or programs or travel or school, whatever you would want to do in that year time, what would you do with it?
That's an amazing question. Sorry, I really have to think about that because I've just taken a
Mhm.
year of sabbatical, but it wasn't, I mean, I was working on my course and I was working on my products and just not seeing patients for a year. Honestly, I would travel a little bit, but the things that I really enjoy are long distance hiking, getting together with my really good friends and eating really good food.
Mm.
And that's pretty much what I think I would do for a year. And it wouldn't necessarily have to be traveling and experiencing a whole lot of different cuisines. It would be hanging out with the people I love, um, going on long walks with them, and then making really good food.
Oh, sounds idyllic.
It's pretty simple. And
It's good.
reading,
Yeah.
filling in the blanks with reading.
Hmm.
So,
Hmm.
yeah.
I love it. Final question. Knowing what you know now, what would you tell your younger self?
Oh, geez. Give yourself some fucking grace.
Yeah. Amen.
Yeah.
Dr. Laura James, integrative oncologist. Thank you for joining me on the show.
Thank you for having me. This has been really fun.
For
And
me
I
too.
hope that what I've had to say has been helpful for people.
I'm certain it will be. I can feel it. Thank you.
You're welcome.
Awesome. The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.